Thank you, Jeff. And hello, everyone. Apologize for my voice. I've come back from Froome with a bit of a cold. Yes, I was with a contingent from all across Canada. There were 28 of us who had that opportunity to visit Helen and Jenny. And so it was really, really fantastic to see you in person and to learn from that whole community approach. So today I'm going to share a little bit about the strengthening community connections. Let me see if I can share my slides. There we go. So as Jeff mentioned, I had the opportunity to do a report for the Chief Public Health Officer of Canada. It was actually a couple of years ago, that was informing her report about the future of public health in Canada, sort of as we were starting to think about what that might look like in the later COVID or post-COVID environment. And there were a couple of different reports that informed hers. Mine was about the role of community and community organizations. There was also one about Indigenous health, one about governance, and one about data. So if you happen to be interested, you can check those out. So I'm not going to talk too much about what social prescribing is, because you clearly know that. I see that well laid out in your own work and in the presentation that you just heard. And I actually had the opportunity to visit Burnaby in October of this year and to see some of the work of social prescribing for myself. And so I won't get too much into that, but I'll really situate some of that work and some of the work you're doing into why I think that the future of public health really is at that local neighborhood scale. So first off, this is what the World Health Organization calls a health system. You can see it's got some very standard looking things in here: service delivery, health workforce, health information, access to essential medicines, financing, and then leadership and governance. From my perspective, that's not all that constitutes a health system. And I think it's time that we updated this model. And so here's what a health system might look like if we really recognized what has been propping up those 6 building blocks, what foundations are underneath those 6 building blocks of health systems. And so these include the work that happens in community. So the household production of health, the work we do as caregivers, for example, the social determinants of health, the work of community organizations, including community health workers and community health volunteers, and community-based health promotion and healthcare services, like those that are delivered by PCNs. And then, of course, societal partnerships and the information and learning and accountabilities we need to really make that happen. This is what a health system actually looks like. And in fact, if you have been following at all the work of the Canadian Centre for Caregiving Excellence, they released an excellent report earlier this year that demonstrated that if we took away the household production of health, the unpaid work of caregivers across this country, for example, the entire health system would grind to a halt by noon on the first day. So this is significant work that has been invisibilized for reasons of being racialized, being feminized, being localized, and so on. And part of what we'd like to do, part of what we need to do, is recognize that community health isn't just a series of discrete and disconnected events. Community health is a sector, and collectively we make a big impact on health and well-being in our communities and across our country. So this is a graph of health spending in Ontario, but health spending in BC looks quite similar. Every province looks a lot like this, and every industrialized country's health system looks in many ways a lot like this. You don't worry about all the details, but I think you can see that under the public spending, the lower half of this spaghetti chart, the biggest funding still goes to the things that mattered, 100 years ago or more in health: hospitals, physician services, and drugs. Okay, so hospitals and physician services are things that were covered, since the time of Confederation, and the addition of drugs during the time of Medicare, 100 years after that. And we're about 75 years after Medicare now, so maybe when we get to 100 years, we'll start really moving the needle on addressing other home-based things: community care, home care, public health, all those things that happen outside of hospitals and outside the work of drugs. And this is something that we know matters and has come up over and over again around the world. And the World Health Organization's, groundbreaking work on social determinants of health a number of years ago now recognizes that meso level, that community. It really does matter as a scale for health, but it has been ignored too much in our health systems. And this is where we can do things, including, but not limited to, policies that help reduce vulnerabilities for people, reduce the disadvantages that people are facing. Of course, it's not the only place where we need investment. We need to work at the macro level of public policies. We need to work at the micro level of individuals. But some of those other levels are recognized and seen already as part of our systems, whereas this community one still isn't enough. So this is what you're doing. You're building health by building community, and I'm really happy to see it. And I'm just going to talk about a few principles that have emerged from my review of the research as being really important when you're doing this work. Number one is just to strengthen that work at the neighborhood scale in primary health care. So primary health care, as defined by the World Health Organization and the United Nations, is not the same thing as primary care in its limited application here in Canada, where we tend to use it to just mean clinical services in family health. So family medicine and nurse practitioners and maybe a couple of other team members, for example. It's something a little more comprehensive that includes essential public health functions and primary care at the core. Wrapped around with empowered people and communities who can really own and govern and drive the work in multi-sectoral policy and action that can link that work with what's going on at those other scales. So you are in this now, and I'll talk more about this and then another one of the actions that are important, but that you do need an empowered and vocal and engaged community to really make this happen, and to make it happen in a way that helps you build a resilient community. And in fact, a lot of the data coming out from the COVID-19 crisis, as well as other crises, including wildfires and others that you have faced, shows that local communities with the strongest social infrastructure fare best, not surprisingly, in times of crisis. So you're trying to build up strong local social infrastructure and physical infrastructure so that you're ready to weather crises. And so the most recent report by the Chief Public Health Officer of Canada is all about emergencies and resilient communities, and really leans into this even further than it did in the one before. And here's where I do have an image of social prescribing, because it's just such an effective tool for getting started on knitting together the different resources and assets and capacities and expertise that you already have in your community in Burnaby, and starting to connect people to them, tracking the results, and demonstrating the value of the work that you're doing. Number two, be accountable for community involvement in governance and decision-making. This is really important. If we are making decisions about the community without including the community, we are not going to succeed. And so we have great examples of this, for example, from populations of people who use drugs, who can connect with peers and share understandings in a way that people not part of the community have trouble accessing and understanding. But we need to move past this too, where possible. We need to move past the nothing about us without us, and move all the way to by us, for us, really doing what we can to ensure that community members, and in particular communities who are facing structural disadvantages and barriers to health access and health equity, are in governing the work that we do. So moving from that sort of paternalistic model of doing two people all the way down to they are taking the lead, and as a group we are providing the supports that they request and decide are important and necessary to do the work. And this really helps us to deliver outcomes that actually matter to people. And we know in community health and social prescribing that a large part of this work is shifting the focus away from what's the matter with us to what matters to us. And being driven by that sense of purpose and meaning is what's going to keep us going when times get tough. It's going to make things more efficient. It's going to be more just. It's going to help us build our own capacities and remind us of our power, and connect us on a more human scale to help tear down some of those professionalizing boundaries that create power dynamics that aren't serving us anymore in health, and maybe never were. So one way to do that is to build community and build equity right into your data collection. So following data collection such as the OCAP principles of ownership, control, access, and possession, which have been led by First Nation groups across Canada, or EGAP principles, engagement, governance, access, and protection, which have been proposed by Black communities here in Ontario, where I live. These are just examples of ways to make sure that communities who are most impacted, whose data are being used, have a say in how those data are being used, how they're being interpreted, what knowledge frameworks matter, what counts as knowledge, and so on. And so there are really great and feasible examples of how to do this in a way that helps keep you accountable for ensuring community engagement all the way throughout, including in the data, so we can start really tracking and measuring whether we're making a difference when it comes to health equity. And of course, this came up during the pandemic when we found we didn't have good health equity data and we had trouble making good decisions and targeting resources under proportionate universalism, which means, having the same goals for all the population, but different strategies for different subpopulations depending on what their needs are. And then the last one is one that doesn't come up often enough when we're talking about healthcare transformation, and that is really, really understanding our history. And so in some ways, it's the truth part of truth and reconciliation, although it's about colonialism as it affects everyone, including Indigenous people, and prioritizing Indigenous people, but also recognizing that it affects everyone. So the way that our health system was set up at the time of Confederation, as I showed in that slide about health funding, it's still very similar to how we are structuring our health system now. And the changes that were made at the time of Medicare, including the protection of fee-for-service models, also continues to affect where we are now. And so we need to just understand and really think about where our health systems come from, so that we can remember and recognize that none of it's inherent. It's all up for grabs. And if we decide collectively that we need to make a change and take leadership in what a PCN could be and should be in a moment where you have an opportunity to make a change, that's a really, really important thing to do, to really understand how you could push past historical boundaries that keep people thinking in the same silos. And I'll just point to this. This comes from the PAHO, the Pan American Health Organization's recent report about just societies, where they recognize amongst structural drivers of health that history and legacy, including ongoing colonialism and structural racism, are drivers of our ongoing health and well-being. So in other words, our social determinants of health, our environmental determinants of health, they come from somewhere. And it's important to remember where they come from. Okay, so the last thing I wanted to say, and unfortunately the image is not showing up here, but I'm really hopeful that you will take a learning health system approach to the work that you're doing, building in data and evaluation and tracking that helps you improve and learn and demonstrate the value of your work. For me, that's maybe the most important contribution that approaches like social prescribing can make to show the value of that invisibilized community health work that you're really advancing. And also, when I was doing the research for this report, so very little of the leading edge expertise in community health and the amazing work happening on the ground in primary care, primary health care, and community health and well-being across Canada and around the world, to be honest, it just doesn't show up. It doesn't show up in the gray literature. People are busy trying to just do the work and get things done. It definitely doesn't show up in the academic literature. And so I was initially tasked with doing a literature review of the academic literature to see what's out there. And there's just not enough. So please do share your work, document it for your own learning and improvement, but also so others can learn from the leading work that you're doing. And we can continue to get the good work of community health on the map.